Good afternoon to everyone who's joining us here today for the question and answer session relevant to COVID-19. I would like to let you know that behind the scenes here a little bit are a round table of experts who are going to do our best to answer any questions that you may have pertaining to this issue. And they can cover all sorts of different areas. The panel itself covers infectious disease, general pediatrics, psychology, nursing, immunization, registry expertise. So we hope we've got all of the bases covered, but it's important to begin with that we all understand that, well, nobody has all the answers, but we're going to do our best to address them. And so I'd like to introduce some of the people that are behind the scenes at the panel right now. Dr. Alan Weller, president of the chapter. Puthamadam Radhakrishnan, also a member of the Executive Council at NJAAP and General Pediatrician. Dr. Jean Kraft, another Executive Council member. Dr. Lawrence Kleinman, who's Vice Chair for Academic Development, Chief of Division of Population Health, Quality and Implementation Science in the Department of Pediatrics at Rutgers Robert Wood Johnson Medical School. We also have joining us is Raymond Hanbury, who's Chief Psychologist, the Department of Psychiatry and Director of Psychology Education at Jersey Shore University Medical Center. We've got Dr. Ruth Gubernick, who, for those of you mostly know her, Ruth does a lot of our data analysis and quality improvement in work. She's here today because of her extensive knowledge of the NJIIS, the immunization registry, and how that may become a useful tool in helping us navigate. We have Marie Sasso, and Marie is the ED of the School Nurses Association. Dorian Vicente, who is president of the New Jersey State School Nurses Association. Judy Smith, who is CEO of the New Jersey State Nurses Association. So we've got a terrific panel, and we're hopeful that they will be helpful in getting all of the questions answered that need to be answered. We're doing—
Michael.
Yes.
You got me.
And I'm sorry, that's because I didn't have you on there. You hadn't checked in. Dr. Peter Waker, again, infectious disease associated with St. Peter's University Hospital. And have I missed anyone else?
Meg Fisher.
And okay, this is why I don't do a whole lot of emceeing these. And Dr. Meg Fisher, who needs no introduction, but we're delighted to have her joining us. So with that said, I want to get to, we are doing this recording. And Kyle, do you have the questions?
Yes, I do.
Okay, so maybe while I'm bringing them up on mine, maybe you would float the first question. Folks, these are ones that have come in advance of today's session. But again, if you have questions that come up while we're doing this, you can use, and you're encouraged to, everybody is muted, so you'll need to use the chat box located at the bottom of your screen. So with that, please, Kyle, let's go with question number one.
Yeah, so our first question has to deal with physician self-care. The question is, as a pediatrician in his 60s with underlying health issues, which put me at higher risk, what additional precautions should I be taking in the office? Or should I not be seeing patients at all?
So Kyle and Michael, I think I can take this on a community pediatrics basis. What I have had with discussions with many people is that, number one, you need to be screening every single patient before they come into your office, before you give them an appointment. You need to know what their background is. And when you're asking questions, most of these questions have been done for the patients themselves. But the important thing to remember here is that they're coming with a family. The child is not coming by themselves. They're usually coming with a parent. The important thing to know is that parent have any of the risk factors that we're looking for. So if they are exposed to any of those risk factors and they need to be in a quarantine, that child should not be in your office too. That puts you at a higher risk. Remember, unless you take care of yourself, you can't take care of those patients. So it's very important to remember to screen all these patients before they come into your office, before you give them an appointment. And the best way to do that actually today is to do a telehealth. And I know we're going to have a webinar on that on Wednesday. So, for those of you who have not started and need some background information on this, please, that is the best way to screen a patient, provide them the telehealth conference consultation, and I'm sure you can get rid of half the patients that you don't need to be seeing in your office.
This is Alan Weller. In addition, I would consider, we've actually changed guidance at our hospital today and are allowing all the clinicians to wear a mask who are providing patient care. I do understand that there are shortages of masks and PPE, and as in the chapter, we are trying to address that. But something to consider is because people are asymptomatic before transmission, and in order to protect yourself, you might want to consider wearing a mask throughout the day. That may give you additional protection because we can only question what people know and what people answer.
This is Larry Kleinman. Also in the New York Times today, there was an article suggesting that anosmia and depression and taste, so smelling and taste, may be an early sign in people with mild symptoms. It's at least worth thinking about whether screening ought to include that for household contacts. This is pre-scientific anecdotal data with also concomitant evidence that ENT physicians seem to be a particular risk to get this illness, and maybe for other reasons.
Thank you. Okay, the next question is, if the coronavirus is in cough droplets, can someone who is a carrier that is preparing your food and coughs contaminate the food?
I can answer that. Well, I could attempt to answer it. This is Dr. Peter Wenger. Sure, yeah, you can contaminate surfaces, you can contaminate food. In fact, there have been certain studies that have shown that there's possibly that it is found in stool on certain patients, and there's certainly people have considered fecal oral transmission with respect to this disease. So yeah, if it's in droplets, they can get on the food, and it certainly can, and you could eat it. And there's considerations that there may be some component of fecal oral transmission.
So this is Meg Fisher. I just want to weigh in on that as well. I think there's a lot of things that could possibly happen. We don't think, though, primarily that this is a fecal orally transmitted agent. We don't know if the virus in stool is actually viable, or whether it's just pieces of DNA. And even if occasionally it is there, at least to date, we don't think that's the major way. So major transmission is still droplet transmission with direct contact, and the CDC says contact for 10 minutes. I believe the New Jersey Department of Health has a little shorter duration of contact, but the major way this is transmitted is droplets.
Right,
yeah, not food. And going back to the first question, I had trouble unmuting myself. For healthcare workers who are immunocompromised, one of the things I think is important is that you talk to your own physician and think about how immunocompromised you are and how safe it is for you to be working in general. As we know, this is not primarily a disease of children, but the children often have parents, and the parents may be transmitting disease. So remember to use simple things. Examine children from their back instead of sitting in front of them. Try to keep some distance between you and the parents who potentially may be contagious. But there's sure a lot that we don't know yet. So a lot of unknowns out there.
Right.
Thank you. Next one, all yours, Kyle.
Great. So what is the recommendation around WCC and immunization? Currently, our health center is conducting visits via telephone, and we'll be moving to telehealth shortly. Patients who need vaccinations are being placed on a list. Are practices having children come in for immunizations? Should we be prioritizing children who are under 2?
So Kyle and Michael, this is Dr. Radigan. So this is something I think that's still evolving. We, of course, don't know how long we're going to be in this present environment. So everybody's trying different things. One thing I think we all agree is that we should not be bringing everybody together at the same time into the office, which means that we no longer bring in sick with a well, and even if you have a different room, it's not that easy. So what most practices that I have talked to are doing are bringing in the kids that are under 18 months old who need those immunizations frequently, are bringing them in, and those who've already had their primary series, we're trying to delay them to take them out. Telehealth is a great way. Again, I have to put a punt in for that. It's that we can see these kids and make sure that they're okay. And when you get kids with rashes or pink eyes or somebody with a runny nose, a parent can take a temperature and call you, and you can see the kid and make sure they're not sick. So the point is to try to avoid bringing them into the office if you can, number one. Older kids who've had their primary series, we're trying to delay the immunizations at least past this next 6 weeks and see what happens. So I think everybody's playing it by ear, but nobody's come out with a recommendation yet. AAP doesn't have a recommendation yet on this. So we're just hoping that, we're going to be able to bring the well kids in later and just bring the babies in right now, and and just make sure that we're not mixing them with sick kids at the same time.
This is Ruth Gubernick. Another strategy that I've heard about is for your patients who are fully immunized, who are 4 years old and are due for well care and booster shots, to just, keep those kids. If you're using the NJIIS, the immunization registry, that'll be an easy way to be able to recall them at a point when it's appropriate for them to come back for immunizations, or if you have that capability with your electronic health record to be able to track that and be able to recall at a later point. As long as they have their primary series, then those can be delayed for hopefully it won't be too long.
This is Larry Kleinman. We have 2 primary care practices in the department, one of which is located at a community health center and one of which is a more private practice model. We had a conversation amongst the clinicians yesterday, and we're actually doing it 2 slightly different ways. And then we're going to re-examine what we're doing. We're not bringing in those who've had their primary immunizations already unless there's a reason to see them. We are pre-screening and not bringing in respiratory illnesses that we believe could be COVID. We are sending those to the emergency room. There really have not been to date. I expect that will change. Those with simple respiratory illness and fever that persists and moves to ear pain or other things, we are doing more prescribing of antibiotics over the phone than we normally would. And for the difference between the 2 practices in the well child care is at one practice, folks are going to get a telehealth visit and asked to come in to get their immunizations, and they will be offered a clinician visit, but the assumption will be it's a shot-only nurse visit initially following the telehealth visit. And the other, the feeling was that the risk is greater for the families in terms of coming in than once they're there briefly seeing the doctor. So there we're trying to shorten visits and take some of the precautions, examine from behind, et cetera. But we are actually conducting the bulk of the well child care in person. And I actually think those are both reasonable approaches. We're going to try to track what patients' preferences are and how they feel about that. We haven't yet developed the data collection tool. That's on me to do this afternoon.
Well, that's terrific, Dr. Kleinman, and that might be helpful as we're moving forward, because there is some mindset that we will begin to do these Q&A sessions on a weekly basis. So maybe there will be more on that to come down the line. And Dr. Fisher, here's one for you. Does infection provide immunity? course, you may be on mute.
No, I think I'm unmuted now. Can you hear me?
Yes.
Okay, my apologies. At this moment, we do not know the answer, but the assumption based on all other coronaviruses and most respiratory viruses in general is that at least it will provide short-term immunity. We don't know if it's immunity for 20 years or for 20 months, but it does appear, we think that it will provide short-term immunity. Peter, you might want to weigh in.
No, I've heard the same thing. I saw some paper, there's 8 billion papers out now, but I saw some papers that said that there was some concern about waning immunity over year, but we don't know yet at this point. We don't even have broad spectrum, serology for this disease. I think once we get that, and it looks like it's about to happen, then we'll learn more about, the immune response to the virus. And as time goes, we'll learn more about how long the immunity lasts and so forth. So I think Dr. Fisher is exactly right.
Thank you. Kyle, you have the next one.
Yes, thank you. As pediatricians, we see or talk to a lot who have mild COVID-like symptoms. Some might have it, many don't. Since we can't get them tested, we don't know. For the individual patient, I understand that testing does not change medical management, but we need to tell them what to do in terms of self-isolation, which is not really completely possible for kids, and self-quarantine. Should they all be treated like patients who test positive and be told to stay home for at least 7 days after symptoms onset and at least 72 hours after resolution of fever and symptom improvement, which are the current CDC recommendations for symptomatic COVID-19 patients? If we are treating patients as if they have COVID-19 without testing, do household members need to maintain home isolation for 14 days after the patient is released from home isolation?
This is Dr. Wenger again. I think there are a lot. This is a difficult issue, and I think, boy, I wish I could give you a definitive answer. The other thing, now that we're not having school, the children they're at home. So then you have to figure out, what do you do in the home? I think the household members, the people who make up the household, that's very important. If grandparents are living there, or people who have some kind of underlying condition, you really have to, and I understand how difficult it is, isolate the children, or separate the children from those people at greatest risk for a more serious disease. I think at this point we have to follow the recommendations of the CDC and the state, as we don't have, I can't say I don't have any more information. I certainly don't have any more information that can give you better guidelines. So I think following those recommendations is probably prudent. But I think you really have to look and give special counsel to people who may have people at high risk living in those households, where you might have a child or any person who's displaying symptoms of COVID.
Thank you. So it's interesting. A lot of the questions that come in, much of it is blanketed in commentary, and the general theme of that commentary seems to be one of great confusion. So just a little pause to thank all of you that are on the panel and all of you that are submitting the questions for being here to kind of be out on the limb doing this all together. And so here's one of those questions that has come in, and understandably presented under anonymity. And that is, if someone in the board of a building, i.e. the Board of Education, has tested positive, how many people in the building should be informed? Speaking of tough questions.
You mean they're on the board of, what do you mean the board of the building?
Well, let's kind of point back to the hospital scenario. If there's a board member or upper level individual who tests positive, is everybody in the hospital notified? Is that a standard protocol?
Michael, this is Alan. I could help address that and share with some of the practices that we are doing. So in terms of some general recommendations would include, we consider that if an individual who's not wearing like a face mask is within 6 feet of an individual for greater than 10 minutes, that might increase the risk of an exposure. So if the person is greater than 6 feet away or within 6 feet and less than 10 minutes, then that's probably not at high risk for a significant exposure. That's just to provide some guidance in terms of that.
Thank you.
So another point, we still do have HIPAA, so you know you can't release information on other people's test results unless it's to a doctor, you know, or someone caring for that patient.
Okay.
All right, so a question about diagnosis. Can you test positive for seasonal flu?
Excuse me, Michael, it's Larry. I just want to say one thing. HHS is looking at HIPAA and how it can be maintained and how it needs to be relaxed for the pragmatic care of patients with COVID, and also contact tracing is fundamental and essential to the public health response, and HIPAA never precludes notification of authorized public health departments. So those are just two things to keep in mind when we think about HIPAA.
Absolutely.
Yep.
And this is Marianne Vicente, President of School Nurses.
Go ahead.
You know, just to piggyback off of HIPAA, you know, New Jersey State School Nurses, you know, we fall under FERPA, and we've always been told that, you know, under FERPA, you know, we can disclose, while we both recognize HIPAA and FERPA. So that also hopefully will be under consideration, because right now we are dealing with lots of reporting, and the school nurses are working from their homes, communicating with families and students and staff and so forth, and the public health department. So there's a lot of confusion with those answers to the state school nurses as well.
Thank you.
All right, so circling back, can you test positive for the seasonal flu and COVID-19 simultaneously?
I think they have found that there can be co-infections. I've seen different estimates. I've heard, I saw one estimate in one paper, and I don't know, Meg, you probably could address this, as high as like, I think 2/3 of those who were positive on the respiratory viral panels also tested positive with another viral infection. So and it's been reported of co-infection with COVID and flu and other respiratory pathogens. So I think just finding that a person has an infection with one virus doesn't totally eliminate the possibility of infection with COVID. Meg, what?
Yeah. So I think in most places it's not, the number is probably not 2/3, but much lower. We are still in a high influenza outbreak situation. Mm-hmm. So I'm not, you know, a person who has typical flu-like syndromes, I would treat them with oseltamivir for their flu and not be quite as concerned about COVID. Yes, it can happen, but it at least in our experience here at Monmouth Medical Center, where we've, of our 13 positives, they were all viral respiratory panel negative. So I don't think it's as common as 2/3.
No, that said, that was one paper I had read where
right.
They reported that. You know, but saying there's a wide berth of a wide swath of values there.
Okay. So here's one we're hearing a lot in the news the last couple of days. What's the role of Plaquenil?
So that's a definite, we don't know yet.
Right.
But I will tell you, I think what many pediatric hospitals are doing, and that is that at least right now, we would like to save it for inpatients. And we don't know if that totally makes sense or doesn't make sense, but we're concerned if it's used in the outpatient setting, we'll be out of it before we get the chance to treat people who may be sicker. It does appear to be evidence that chloroquine or whatever its name.
Hydroxychloroquine.
Thank you, hydroxychloroquine with azithromycin may have some activity. Remember, both of them prolong the QT.
Right.
So just be careful when you're using it. There is nothing as of this day, this hour, that we can absolutely say is useful. There is a new antiviral out there that there was just a New England Journal of Medicine article, but I don't think that's been tested in children, and I don't even know if it's available. Do you have any more info, Peter?
Are you talking about the remdesivir?
No, not remdesivir, the one that was used in China. Remdesivir, I think we really don't have good evidence that it's going to work,
Right.
and at least some of the people who have worked with it say it may work to prevent disease if you're exposed, but it doesn't look like it's so great once you have symptoms, at least in the animals.
So this
Yeah,
is,
again, for treatment, there's really not much. I mean, people are obviously looking at it, but there's no definitive data. Let me just preface, yesterday I just tried a little experiment of my own. I tried calling up pharmacies, local community pharmacies. They're all out of hydroxychloroquine or chloroquine, and their vendors are. They couldn't get it.
yeah,
And in fact, I was surprised to find that many could not were out of azithromycin also. So, and again, who know, again, as Tony Fauci and stuff has said on TV, we don't know it yet, what a really efficacious treatment is.
so it's Alan Weller. Also, just to elaborate, I want to stress to folks that in primary care pediatric practice, we should not be prescribing this, nor should we be prescribing it for prophylaxis at this point in time. There's also a very large concern in the pediatric community that those kids who are on the meds for other reasons, for like certain rheumatologic conditions, will have challenges getting access to their medications. So until data is out there, we're please asking people to not prescribe it to their patients and to not prescribe it for prophylaxis. And we will continue to have updates on a weekly basis as there is more data available on this.
Yeah, that's absolutely, Alan. Let me just make a comment. I heard Governor Cuomo yesterday sort of use an example that there are not many cases in Africa, and that malaria is widespread in Africa, and it's probably because they take chloroquine to prevent it. That might be protecting Africa. That really doesn't make a lot of sense. Most of the malaria in Africa is chloroquine resistant, and people are not taking it continuously. And there's also malaria in Asia, and it doesn't appear to be protective there. So I think there was a run on pharmacies because of certain statements like this. So I think Alan's statement is very well taken. Don't prescribe it.
Thank you. Okay, here's one. If COVID-19 becomes seasonal in likeness with influenza, excuse me, and children are largely asymptomatic carriers, do you see this potentially being something to consider when giving nebulizer treatments in the school health office?
This is Dr. Rad. The current talk on most of our webs and stuff like that is that not to give nebulizer treatments in the office at this time because of the potential of aerosolizing the COVID virus. And at this point, that is the recommendation that all of us are following. Things like Mike says, this is the current state of knowledge. We're hoping that we'll know more once we get some of these serology testings in place, and it'll give a better idea of who's a carrier and who's not.
Mm-hmm.
But till that point, at this point, the recommendation is not to use nebulizers in the office with the potential of aerosolizing the virus.
Absolutely correct. So MDIs, you can use MDIs in the office if you can,
Right.
if you have spacers and stuff, that would be ideal. Remember that it is not clear that children are carriers and are transmitting it. You know, if you look in China, less than 2% of cases were in children. In Italy, 1.2% of cases were in children less than 18. And in our case, it was clearly the adult who was sick and gave it to the child. And that has been the experience with SARS and with MERS, where children are just not much involved. So I don't think you have to worry that every child walking around is likely to be a carrier and is going to infect you. But I think we are all trying to decrease things that aerosolize viruses. And in fact, when you're giving those treatments in your office, you're probably aerosolizing influenza and RSV and everything else. So we should have always been more careful with the protective equipment.
Thank you.
That's all.
So there's a question here that says, why are asymptomatic healthcare workers still allowed to work even when known to have been exposed to COVID-19?
This is Alan, and this is CDC guidance specifically for healthcare workers. And one of the reasons for this is that it is a major workforce related issue. So in terms of that, in terms of safety, those individuals who are known to have been exposed within the CDC guidance are being asked to wear a mask at work, and also processes are generally in place at institutions to ensure that they only work when they're asymptomatic. They are questioned upon arrival at the hospital. They receive a temperature check before they're allowed to work on whatever respect of unit. So that's sort of the guidance that's been coming out of the CDC, and that's how it's been implemented at many of our local institutions.
Yeah, Michael, you know, the thing is that this is a huge, major public health issue, and we need to have the soldiers on the front line, and unfortunately, that's us. So as long as we have no symptoms and we're not, at this point, considered a case, then we don't fall under the same the guidance. And you can't be really, you know, putting everybody at home and saying, okay, you need to be in isolation for 14 days. That'll be every single ER physician that you can think of in this country at this time.
Thank you. So a number of questions here have revolved around the length of being contagious. And this one is specific to, does a healthcare worker who tests positive need to be retested in order to return to work?
Well, as far as I know, that the guidelines are that if you tested positive, then you've got to have 2 negative tests before you're released back into the workforce again. Megan?
So that one's not true. So and again, this is changing by the hour, by the minute, but the 2 negatives, that's for people who are chronically ill, who are in the hospital. In order for you to stop their isolation, you should have 2 negatives. For healthcare workers, it's a little looser. So, you know, remember, so you may return to work after you've been asymptomatic for 72 hours, provided it's at least 7 days. The question remains, should you be wearing a mask or not when you return to work? Because in fact, we don't know how long people are contagious. So personally, I would probably wear the mask for at least another week, so that it's a total of at least 2 weeks that you are masking. But I think, Dr. Rad, I think that was the original question was, you know, should a healthcare worker, how long do you have to wait? There's 2 options. You can have the option where you do test the person, and then you have to have 2 negatives 24 hours apart, or you can do just the time-based one, a certain amount of time after symptoms. At the moment, we don't have a lot of extra tests available to be testing healthcare workers, and we certainly don't necessarily want to be testing asymptomatic healthcare workers.
Okay.
All right, so a question that I think goes along well with questions about testing and capacity. Are there places where school nurses can volunteer like a testing site?
This is Doria Vicente, President of School Nurses. We sent out multiple requests from NJSNA. Judy Schmidt is on the line as well, where they could contact through Judy Schmidt. Also, all our county presidents have been alerted to county locations for volunteers. So you can contact your county school nurse president, and they'll be able to give you that information.
This is Judy Schmidt. We do have a email site that we're utilizing for volunteers, and it's COVID, COVID 19 volunteer@njsna.org, and I'll give that information to Michael.
That's terrific. Thank you.
Hi.
I'm sorry, this is Alan Weller again. I just want to respond to the prior question because I'm reading current guidance online for suspected healthcare employees. So the information given by both Dr. Radhakrishnan and Dr. Fisher are both correct. There are two options currently available. One is the test-based strategy, which is what Dr. Radhakrishnan had mentioned is now considered acceptable for returning to work, and the non-test-based strategy, which was what Dr. Meg Fisher had recommended. Both under current CDC guidance are appropriate, and the current return to work practice and work restriction is to wear a face mask at all times until all symptoms are completely resolved or until 14 days after illness onset, whichever is longer.
Thanks, Alan.
Sure, that's current guidance, folks. Sorry to interrupt.
This is Marie Sasso from New Jersey State School Nurses. All the counties have the Medical Reserve Corps, and many school nurses are part of that and are volunteering through the Medical Reserve Corps.
Terrific, thank you. And so I'll point out, Judy, I don't know if you saw my text, but the email addresses, any of the panelists, if you enter those into the chat box, they will be accessible to all of the members. Just make sure you're directing it to everyone and not just an individual. So that would be a pretty seamless way of making sure we get that information out. There are also a lot of questions that revolve around well visits and seeing patients and many of them unless it's for an emergency scenario, should the well visits be postponed?
Michael, so I think the general consensus is that the younger children who need their primary immunization series, you should try to make some accommodation for them to come in at a time when there's nobody else there so they can get their immunizations. But for the older kids who've already had their primary series, the consensus right now is at least to postpone their visits till we know better as to how to deal with the situation. And I think I heard the same thing here too, is that most people prefer to do that and to try to cohort them together away from the sick visits also.
Yeah, this is Jean Kraft, the Vice President of AAP, and I'm a pediatric intensivist. And I think that one of the things we need to remember is that COVID-19 is occupying a lot of our energy and thinking, but the reality is that it doesn't protect you from other stuff. And there, you know, I personally do not want to see a resurgence of H flu or pneumococcal disease or measles following this COVID-19 outbreak because children haven't been immunized. So I think it's important that we pay attention to the fact that children, there's some care that can be rendered via telemedicine, and there's actually going to be a webinar on Wednesday about that. But specifically the rules about using a system that has been adjudicated to be HIPAA compliant is not going to be enforced during the epidemic. So there are a lot more platforms that are available for pediatricians for things that don't actually need to be seen. But babies who need weight checks, I think that children with chronic disease who really do need to be seen, children with urgent things that can't necessarily be addressed by telemedicine or over the phone. We can't not take care of children who really need our care because we really want everybody to just stay at home and not come to the office. On the other hand, as was suggested, it's the primary care of the primary series of immunizations are really, really important. Maybe your 11-year-old doesn't get the HPV until they're 12. So that may be a patient that doesn't need to come in until this is all, has settled down a bit. So I think that, we're in this job because we want to see children be healthy, and we don't want to let things slide that really we shouldn't let slide.
And this is Alan. I want to just state that the executive committee of the NJAAP is in full support of what Jean Kraft has just elaborated right now. We must not let the healthcare of children suffer during this pandemic. In addition, other issues are coming up, certainly lots of mental health and mental health related issues. We are concerned about increases in child abuse because of financial and economic stressors on families. And personally at the hospital, I'm seeing a lot more teens coming in with vaping induced lung injury again because they're vaping since they're home and not really doing a whole lot.
This is Larry Kleiman. To add to the child abuse, intimate partner violence is likely to go up under these circumstances. And that's something that harms children and families, and we need to be aware of. Also, and I don't mean to be cynical or take a business or profession-centric perspective, but to the extent that we say things are optional now, some of that may get thrown in our face later. So we should be careful about saying, well, the physical exam isn't necessary. We should be judicious and thoughtful. And we should postpone what can be postponed, but just remember that all decisions have consequences, and we are going to be constantly in a state of balancing the desirable and undesirable consequences.
I couldn't agree with you more.
Another thing that we are in a unique position to offer is sometimes what families need is not necessarily what we think about as a traditional medical service, but maybe they need to know that, for instance, the Morristown Soup Kitchen is giving out lunch bags every day at noon to anyone who's hungry. We need to perhaps help our family relieve some of the outside stress, and that may mitigate the, always concerning, thing that hangs over our heads about intimate partner violence, about child abuse, about stress in the homes. I recently read that Aunt Bertha, which is a website that you put in your zip code, and it shows you services, resources within your zip code. They just, within the last week, have added 300 new organizations that are helping people who are hungry or need a place to be, or whatever resources. So I think that that's one of the things we do have that we can offer families, because often that kind of stress manifests as a medical complaint.
Thank you, Dr. Kraft. I just want to point out to everybody, if you're looking at your chat box, Judy Schmidt put in that information about where volunteers could be used. So I encourage you to take a look at that and make sure you capture that particular information if it is of interest to you. Getting around to the masks, the question is, what do you think about the reuse of masks because of the shortage?
Michael, so at this point, I do believe the recommendation that if you are using a mask, you can use it all day is the prudent thing to do. As long as you're not taking it off and putting it on every 5 minutes. The point is, if you've got it on your face and you're not taking it off, you're still under the same protection, so it's fine. The problem is when you start taking it off and try putting it back on each time, then you're contaminating the inside too. Is that right, Peter or Meg?
Yes, I would agree entirely. And I think for the usual outpatient setting, that makes perfect sense. But remember, if you're in the hospital, you're seeing a patient who's a person under investigation or actually has COVID-19, then obviously you're going to use different PPE, some of which we are reusing.
Yeah, again, when you're saying masks, you mean the surgical masks you're talking about? Yeah, you have to be careful about handling it. Sometimes there's nothing else we can do. If you have no more masks, it's probably better than nothing. And just a note, and I'm sure everyone here is familiar, if you're talking about respirators or N95 or surgical N95 respirators, make sure they have to be fit. I mean, you just don't pick one up and use it. It has to be appropriately fit, and for men that means you have to eliminate facial hair, so beards, and you can't have a beard and use an N95 respirator, but I'm sure people are aware of that. The CDC put something out today. If you don't have masks at all, they talked about bandanas and wrapping, but they also had a caveat that there's no evidence that those things work.
Yeah, and for those folks out in the ambulatory world, it is probably limited need for N95 respirators. This is droplet-borne precautions for COVID-19 as recommended by CDC and WHO. So it is the use of the standard mask, the standard surgical mask, which is appropriate. The areas of concern are when you are, if you're doing a nebulizer, which is why the recommendation is to not use the nebulizers currently in the office.
Right.
If you're using nasal pharyngeal swabs, and in some situations, perhaps even throat cultures, which is a little problematic for us, because if they're going to cough in your face, that's a bit of an issue. But having said that, just to ground everything is that we're not seeing a lot of disease of COVID-19 in younger children, just to reiterate that at this point in time.
Right.
Okay. Kyle, you have another question?
Yes, sorry, I was on mute. Assuming school will reside in the fall, what about the mandated Tdap and meningitis vaccines that are required for 11-year-olds, given the likely backlog that will be seen?
Anybody stepping up to that one?
This is Dorian Vicente. Again, because this is just so unknown and we are not going back to school anytime soon right now, if all dies down by the summer and re-entry for September, I would imagine those requirements still remain the same.
And this is Ruth Gubernick. I would expect that the State Department of Health would also look at, keep in mind there are the provisional admittance that's allowed for students who are due for shots, and I'm sure that they will handle that accordingly so that they're not prevented from coming back to school if they're missing those vaccines.
Yeah. But this is, Alan, again, just to reiterate what Dr. Kleinman had said earlier, this is extremely important. We consider vaccination of children, a high level importance, and we need to come up with systems in place that allow that to be done safely. So in the worst case scenario, perhaps that may be necessary, but as time is going on, we're just going to help our members and our other pediatric colleagues to be able to create systems where that they can safely assess and administer these vaccines to these kids, because there are lots of consequences and unintended consequences if we don't do that.
Well, and I
Mhm.
suspect for
Absolutely.
those vaccines that are not so quite as time related as the 2-month, 4-month, 6-month vaccines, that I would expect that we would see some offices offering clinics in the same way they offer flu clinics. You know, that they may have an afternoon where it's just everybody getting their Tdaps or their DTaps, depending on how old they are. You know, this is, I think the aftermath of this, the practices aren't just going to go back to exactly what they were doing before. There's going to need to be flexibility for things that are not as time sensitive as others.
Okay,
Yeah,
thank you.
this is Larry. Just to add to that, I would expect whatever backlog in immunizations exists, that the pediatricians, the family docs, and the local health departments will all have to collaborate to rationally develop an approach to doing that. But let us look forward to when that problem emerges, because right now we're really in an acute phase.
Yeah.
Okay, thank you. So we're closing in on it here now. A couple things I'd like to point out, maybe a question or two additionally. But Felicia has just bring your attention to in the chat box a site that is matching medical offices, hospitals, etc., with biomedical companies that have supplies available. And there is a website URL that is posted there, so definitely take note of that.
It's Michael, it's Alan. I said, I was just looking at the chat bot. There have been a couple of questions on what to do about newborns whose mothers are COVID-19. And what I will do is we will distribute a current CDC guidance and recommendations to folks about that. But if a mother is COVID-19 and under investigation, as long as they're doing well and afebrile, we are sending the babies home with the mothers. That's meaning the mother is afebrile and well. There is really, data does not suggest that there is any perinatal transmission to the newborns. And there is limited data available on terms of breast milk, but in terms of prior experiences with other coronavirus infections like SARS and MERS, is that there's never been demonstrated to be in the breast milk. So what we are recommending to parents when they're going home is to take all precautions when she's feeding her infant. That would include washing her hands before touching the infant and wearing a face mask if possible while feeding at the breast. In addition, another option would be for the mother to express breast milk with a manual electric breast pump, and then the mother should wash her hands before touching any pump or body parts and follow recommendations for proper cleaning after each use. And then, if possible, then another individual can feed the express breast milk to the mother. So those are different options. We will get the current CDC guidance to everybody after this conference is over.
Thank you, Dr. Weller. So here is one question that I find kind of very interesting. And that is, how do you possibly tell people not to vaccinate when the crazies out there would leap on that and say it's all nonsense? See, you can delay it. How do we respond to that?
Well, that's one of the reasons why we're recommending that vaccination schedules not be interrupted, if at all possible.
Yeah, you could also say these are highly unusual times. This is not business as usual. And, you know, we're trying not to delay them, but you can't use this as some kind of example for, you know, advocating for delayed vaccines. This is so unprecedented, at least in recent history, you know. I would need some of the stuff they say. I don't even know how to do a retort, but that's ridiculous.
Indeed. So there's one, and then we'll just get on with a couple closing comments here, but there is a lot of talk about not taking Motrin if one has COVID-19. Thoughts, advice?
Yeah, I think the jury is still out. You know, they talked about ibuprofen and NSAIDs. There's a lot of interest around ACE, ACE2 protein, glycoproteins on cell surfaces. That's what the virus uses as a receptor to infect human cells. And there's a question that ibuprofen upregulates those particular receptors. I don't think there's any actual clinical evidence. And so it's like ACE inhibitors for people with hypertension. So I don't think there's any general recommendation for that, though the WHO at one point put out a thing, try to avoid NSAIDs if possible. But again, there's no hardcore evidence that it would be detrimental.
Right, and the FDA recently released a statement saying there is not enough clinical evidence for or against the use of NSAIDs in COVID-19. Having said that, you all know that I am a fever is your friend kind of person, and I think that we know the body's defenses to this viral illness are fever and inflammation, so why would you give them a medicine that takes away both of their natural defenses?
Right.
So I think that's true in general. Obviously, there are exceptions. The person who's in congestive heart failure, whose fever puts them over the edge, sure, give them an antipyretic. But in general, you're taking away the body's defenses, and to me, you're therefore giving the virus a benefit. So I would think twice before we take away body defenses.
Right. Hopefully, this will take away the standard order of giving antipyretics for anyone who spikes a temperature in the hospital, any child. Hopefully that it will end that practice.
Thank you, doctors. So in closing here, I would just like to point out a couple of things. Number one is, as I indicated earlier, we're considering doing these on a weekly basis. And so my ask of the participants that are out there, over 400 of you, is to ask if you found this helpful and worthwhile, please let us know that. Just drop us a quick email that says, yeah, I'd like to see this happen again next week, and continue on along those lines. That would be very helpful to us. Two other things, and then I'll leave the closing comments to Dr. Weller, and that is on Wednesday of this week, Dr. Radhakrishnan referred to it a couple of times. There's the telehealth webinar that's being conducted by Dr. Rad and Richard Brodsky, and that is at noontime on Wednesday. We encourage you to jump on that. Registration is very high on that, but I believe that there is still room. And then on Friday of this week, an update to the original COVID-19 webinar that was presented by Dr. Fisher will air, and that also will be from noon to 1 o'clock. And now I'm second guessing myself on that one. You could check the website and we'll get the information out and everybody will receive it. But is that later in the afternoon on Friday, Dr. Fisher?
No, I thought it was noon, but
okay.
I have to check myself.
So, well, we'll let everybody know, but for the time being, go with that noon. You can check the NJAAP website. All of that information is freely available there. And as will any of the information that appears webinar or recording for sessions like these, they will all be archived and made freely available to everyone. We will go back and look at all of the questions, and for those that aren't answered, we will come up with some answers for those questions, or we will let you know that there is not an answer to that question presently. Next week may be a different story. Having said that, Dr. Weller, is there anything you'd like to say?
Sure. First, I would like to thank all of our panelists for joining today. Just thank you all very, very much. And to all the physicians and other participants today, I just want to let you know that the NJAP is an organization. We are there for the kids. We are there for the clinicians taking care of these children, and that we're going to be doing whatever we need to do to ensure that we're continuing able to do that. I know there's been a major concern about the lack of availability for PPE in terms of practicing in ambulatory settings. We are aware of that. We're hearing that from members. We are reaching out to the New Jersey Department of Health as well as to the emergency management organizations within the state of New Jersey in order to try to get more PPE masks and gowns and gloves to New Jersey pediatricians. But as you folks know, there is a nationwide shortage of this sort of equipment. So we are doing our best, and we will keep people posted on that. And to all our members and our visitors, if you do like this, as Michael said, please let us know via email, and we will keep the conversation going. We will absolutely respond to the questions that have been submitted that we didn't have a chance to get to. And I just wish everyone to stay safe and be well. And we will continue to do as we all doing as clinicians. We will take care of the kids in our communities. So thank you all very, very much.
Thank you.
Thank you.